Good evening. I'm psychiatrist Jay Fulver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 27th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call in the Fort Wayne area by dialing 969-2720, or if you're calling coast to coast, you may dial toll-free at 866-969-2720. Now on a fairly regular basis, I am broadcasting live from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And I'll start tonight's program with a question I recently received. It reads, Dear Dr. Fulver, I feel like my mind is always racing and is always full of so many thoughts. Is it normal, and is there anything I could do to calm my mind? Your mind racing can be from a lot of factors. If it's all the time and it's been occurring since childhood, that could be a condition called attention deficit disorder. ADD, also known as ADHD, if you have hyperactivity and impulsivity, is a phenomenon where your mind will go from one thing to another, and you can be highly distractible, but you can be, on the other hand, fairly focused if you are interested, challenged, or find something new and exciting. So your mind might be racing on day-to-day issues, and people will say it's like a squirrel going from one thing to another, but that's from ADHD. So if your mind is racing more often than not day by day, and it goes back to childhood before the age of 12 years old, well, that could be ADHD. It's a treatable condition. It's the type of thing where the question always is, what severity of ADHD or ADD would somebody have? Do they need medication? Do you need coaching techniques to try to help with that? Secondly, you could have your mind racing from what's called generalized anxiety disorder. Generalized anxiety disorder is where your mind races due to worry, and you're ruminating, and you're asking what if, and you have a lot of doubts, and you're always apprehensive about the future. That too will cause your mind to race, and that can be a phenomenon that needs to be addressed, ideally with talk therapy. Rarely does somebody need medications specifically for generalized anxiety or severe worry, but talk therapy is very good at addressing the worry, because one of the best ways you can address worry would be to keep a worry diary. Write down your main worries and apprehensions about the future. Keep them in a diary, right beside your worries, what you can do about them, if anything, and the things in which you don't have any control, let them go. Look back on your worries from 3 months ago, 6 months ago, and you'll often find that the things in which you were most worried 3 months and 6 months ago resolved themselves. They really didn't come about, wasn't a problem. There's another type of racing thoughts people can have besides ADHD or generalized anxiety, and that's where you have bipolar mania. When you have bipolar mania, it means you episodically, just once in a while, have spells where your mind will be going really, really fast. You don't need to sleep typically. You'll be very impulsive. You'll do things and say things you ordinarily wouldn't do and say. That's a condition where you need a medication for mood stabilization, kind of like a cruise control for a car. Because if you have those highs where they're just occurring once in a while, a few days here, a few days there, you're more likely to crash into big lows. And with the big lows, that's where people have difficulty with functioning day to day. They have trouble getting out of bed. They are very fatigued. They want to withdraw from everybody. So it really depends on the nature of the problem that would cause you to have racing thoughts, but there's a lot of different reasons why people could have racing thoughts. In my field, I often find it's attention deficit disorder, generalized anxiety, or perhaps a condition called bipolar disorder. Those are the three main ways that I've seen people experience racing thoughts. Thanks for your email. Let's go to our first caller. Hello, Darlene. Welcome to Matters of the Mind. Darlene, you'd mentioned that your anxiety often spikes in your blood pressure, causes spikes in your blood pressure. What's the connection between anxiety and high blood pressure? When you're highly anxious, Darlene, you'll notice that your heart gets racing. Basically, it's a chemical cousin of adrenaline getting fired off there, norepinephrine. When norepinephrine goes up, when you're highly anxious, that gets you more alert, and that's a good thing. So high anxiety makes you more alert and helps you focus on the things upon which you need to focus, but that high norepinephrine can cause you to have a racing heartbeat and sometimes constrict the blood vessels. That thereby can increase your blood pressure. So for that reason, many people who have anxiety that directly leads to high blood pressure will be put on a medication, for instance, like a beta blocker. A beta blocker will be a medication like metoprolol, propranolol, atenolol. These are medications that will block adrenaline, and they block the receptors for norepinephrine, and in doing so, they can decrease your heart rate and thereby decrease your blood pressure. And also relaxation techniques are very common for people. Deep breathing techniques where you're focusing more on exhaling than inhaling. You got to do both, but take fewer seconds inhaling than you do exhaling. So you might take 4 seconds inhaling, 8 seconds exhaling. When you exhale, you actually give your brain and your whole body a so-called parasympathetic effect where it slows down the heart. So if you focus on relaxation techniques, they can be very helpful in helping you with the high blood pressure directly related to the anxiety. Darlene, thanks for your call. Let's go to our next caller. Hello, Jessica. Welcome to Matters of the Mind. Jessica, you want to know about, I think you're talking about zuranolone, Zurzuvae, for postpartum depression. Brexanolone is used for, it's a medication called Rexulti. Brexanolone is a medication that is used for post-traumatic stress. It's used as an add-on for depression. It's used for schizophrenia and even bipolar mood stabilization. But I think you're referring to Zurzuvae, also known as zuranolone, for postpartum depression. So zuranolone is a 14-day treatment. You have postpartum depression, which can be treated within 1 year after delivery. It's where you are incapacitated with severe depression, and it's directly related to delivering the baby. So zuranolone or Zurzuvae is a medication that works entirely differently than any other medication that we are using for depression. The typical medications for depression affect serotonin, dopamine, norepinephrine, and the newer ones affect glutamate. Zurzuvae or zuranolone primarily affects GABA. So it's thought that when people have disturbances in GABA following delivery, they can have severe depression. It's basically a 14-day treatment with a medication that, as its main side effect, will give you difficulty with sedation, that typically people will be dosed in the evening with food. It gets absorbed better with food, so you take it around dinner time. You don't drive for at least 12 hours after taking Zurzuvae. It's not excreted significantly at all in the breast milk, so it's thought to be safe during breastfeeding. But Zurzuvae or zuranolone is being used for postpartum depression. We've seen it in our clinic give people dramatic benefits within a matter of a couple days in many cases. About 1 out of 3 people might need another dosage by the end of the year, but about 2 out of 3 people don't. But it's a 14-day treatment, not unlike an antibiotic, but in this case, it's a 14-day treatment for depression. Thanks for your call. Let's go to our next caller. Hello, Milton. Welcome to Matters of the Mind. Milton, you want to know, is hoarding a form of obsessive compulsive disorder or anxiety, and what's the difference between hoarding and simply collecting? Hoarding used to be thought to be an OCD subtype, Milton, but now it's thought to be kind of in a class of its own. It's probably an anxiety condition. True hoarding is where you will collect things unnecessarily to the point of the environment around you being unsafe. In other words, you're hoarding and you're collecting so many things as basically filling up your house, and that's where you know it's a problem, and it's a problem where you feel anxious upon attempting to get rid of this or that. Now, simply collecting, that's fine. If you're collecting something as a hobby, that's not necessarily hoarding. When you're collecting, you have a purpose behind it. You might even trade to get different collections, but with collections, there's a purpose and there's meaning behind why you're collecting. With hoarding, you're just keeping stuff, and you just having a hard time throwing things away, and you get actually anxious when you attempt to clean things up. So with hoarding, it can be an unsafe, unsanitary, and unhygienic type of environment, and that's where hoarding becomes a problem, and it's thought to be somewhat of an anxiety disorder, no longer thought to be a subtype of obsessive compulsive disorder. It's a different type of variant than that. Thanks for your call. Let's go to our next caller. Hello, Carrie. Welcome to Matters of the Mind. Carrie, you want to know about borderline personality disorder and when did the symptoms occur? Basically, Carrie, borderline personality disorder develops in childhood, and it's basically related to you're having difficulty with attachment with your parents. And in the old psychodynamic literature, it was primarily the maternal attachment that was problematic, but I think it can be any parent or even grandparent, any caregiver, where you're having difficulty with an interpersonal attachment because of their not being interested in you or kind of having their own issues in which they're dealing, so they don't really form that bond, which is particularly important before the age of 3 years old. It's called rapprochement. from a psychoanalytical standpoint, but by the time you're 3 years old, you should be able to be more attached to a caregiving figure. If you're not, over the course of the years, you can have symptoms often occurring in adolescence, but they're very notable as an adult because many adolescents will have a lot of symptoms of borderline personality disorder. That's part of immaturity, that's part of growing up, that's part of the front part of the brain growing, because the front part of the brain, as it's growing, you'll get over such difficulties as moodiness, impulsivity, difficulty with rage, anger, you'll be able to control your temper more. That's a frontal lobe type of disturbance. People with borderline personality disorder not only have difficulty with attachments and very needy clingy relationships, but they'll often have trouble with mood, anger, irritability, depression. Many people with borderline personality disorder are inadvertently diagnosed with bipolar disorder, but when you ask them when do they notice the mood swings, it's typically after they felt rejected or they feel very alone, they feel like they don't have any strong relationship in their life at that time. So people with borderline personality disorder will have moodiness in relationship to their environment or interpersonal reactions. So it'll be directly related to that. You treat it sometimes symptomatically with medication for mood stabilization based on what the symptoms might be, but the best treatment for borderline personality disorder will be a therapy called dialectic behavioral therapy, in my opinion. DBT is a therapy that helps you focus on the here and now. You're not going back into your past and reliving all those things. You're focusing on the here and now, and you're learning coping mechanisms to go from this day forward. Many people with borderline personality disorder do have a history of emotional, sexual, or physical abuse, and if that's the case, there might be a component of post-traumatic stress there. If that's the case, the best counseling treatment would be eye movement and desensitization reprocessing, also known as EMDR. So EMDR is very good for PTSD that could be related to borderline personality disorder. But the key is, from a proper diagnosis standpoint, it might be considered to be a variant of bipolar disorder, but it's a type of variant of bipolar disorder where the moodiness is related to people and situations. So that's a big, big differentiation there. Let's go to our next email question. Our next email question reads, Dear Dr. Faulver, can a bad diet cause you to feel more depressed or anxious? I'll give you a definitive answer there. It depends. If you notice that when you eat gluten, when you eat a high carbohydrate diet, you feel really lousy, kind of track back to, okay, what did I eat? When did I eat it? When did I start feeling lousy? It's different for everybody. Some people can tolerate certain types of foods and others cannot. Red wine, I've seen some people have horrific responses to something like red wine, whereas other people do fine with it. So I think it really, really depends. Definitively, I'm not going to prescribe a diet for every single person out there because everybody's different, but it really depends on what works for you. So if you find that when you eat really good biscuits at a particular restaurant and you feel lousy about 3 hours later, that could be the gluten in those biscuits, and you might have a gluten intolerance. When a gluten intolerance is really bad and you have gas and diarrhea after eating those type of things, that's called celiac disease if you have certain testing that confirms that. But many people have gluten intolerance without the full-blown celiac disease itself. And gluten intolerance is basically where you feel really lousy after eating wheat products. Thanks for your email. Let's go to our next caller. Hello, Phoenix. Welcome to Matters of the Mind. Phoenix, you want to know what are some of the coping mechanisms that you can use to help with trichotillomania to avoid pulling out your hair. Number one, Phoenix, be aware of you're doing it. Some people will notice that they're pulling out their hair, and back in the old days, people would be told to wear white cotton gloves. You don't see that so often anymore, but white cotton gloves are a means by directly treating the trichotillomania. If it's socially appropriate, you can wear white cotton gloves in the public, but many people will just wear them at home because if you have the thin gloves on, you at least know where your hands are and what you're doing. But many people will have the hair pulling occur, and it's totally unconscious. They just have no idea they're doing it. I would suggest having something else in your hands when you're at home, fidget little mechanisms. There's all sorts of different things you can have, but have a pen in your hand, be holding something more often than not in each hand. Most people will tend to pull their hair with one hand or another, and it's a habit they get into. And if that hand, say it's your left hand that's pulling your hair the most, make sure to always have something in your left hand. Yeah, we use medications trichotillomania, inositol has probably been the most effective treatment I've ever seen. It's a supplement people will use. And sometimes people will use serotonin-type medications like Zoloft or Paxil or Lexapro. They're kind of okay with trichotillomania, but the bottom line is I find that from a behavioral standpoint, that's what's most effective, knowing what your hands are doing and keeping that in mind. Thanks for your call. Let's go to our next caller. Hello, Elizabeth. Welcome to Matters of the Mind. Elizabeth, you had mentioned that you know someone who's a recovering drug addict, but was just prescribed a medication from a psychiatrist. It's a controlled substance. Why would they get a controlled substance? It depends on the situation and the reason behind that, Elizabeth. If somebody is a recovering drug addict, we have to go back to square one. I saw a person today with a similar type of situation. If they are using drugs of abuse, why did they start to use drugs of abuse? And if they started using drugs of abuse because of anxiety or depression or difficulty with focusing, you want to go back to the original reason why they started using the drugs of abuse, because they've been possibly self-medicating. Many people will do that with alcohol, opiates, narcotics for that matter. Opiates or narcotics, they'll self-medicate underlying symptoms. So what we're often trying to do is, okay, we're aware that we don't want to exacerbate or create any craving for them for the substances that they used to abuse, but we want to replace it perhaps with something that will take care of the underlying problem. So let's say you took opiates or narcotics and you were abusing those because you just felt depressed and you liked the feeling of bliss that you got from the narcotics. By all means, maybe we can treat the underlying condition with an antidepressant medication. Now, there are some medications that are controlled. These medications can be prone to abuse, and sure, we have to be careful about using those kind of medications with people who are prone to abuse. But there is a medication that's controlled, for instance, called Spravato. Spravato can give people a little bit of a dissociative feeling where they kind of feel out of touch with reality for about 20 minutes after they get the nasal spray in a closely supervised situation. It's a controlled medication. We have found that we've been able to use that for people with a history of drug abuse, because if their history of drug abuse was caused by depression and Spravato treats the depression, we take care of the underlying condition that caused the drug of abuse problems. So it comes back to, is the controlled medication addressing the original problem? And number two, as you're monitoring people in that kind of situation, is the controlled medication that's being prescribed exacerbating the underlying condition where they had difficulty with craving drugs of abuse? So we're always monitoring those type of things. But number one, try to treat the underlying problem. Number two, monitor somebody to see if they're having any craving for the drugs of abuse. Thanks for your call. Let's go to our next caller. Hello, Thomas. Welcome to Matters of the Mind. Thomas, you want to know about the benefits of Spravato as a nasal spray as opposed to taking an antidepressant in a pill form. Are there side effects? With Spravato, I just mentioned that my office had treated over 5,000 treatments with Spravato over the course of 5 years. And it's a nasal spray where you're monitored in the office for a 2-hour time period, twice a week the first month, once a week the second month, and then once a week or every other week thereafter. So it's a nasal spray. And it used to be thought that it had to be always used with an oral antidepressant. That's how it was approved for several years. And just about the middle of January, it got FDA approval, Food and Drug Administration approval, to be used alone. And that means that somebody can take it without an antidepressant medication. The analogy I often think of is eating strawberry rhubarb pie by itself versus always having it a la mode. I always had strawberry rhubarb pie a la mode because of the bitterness of the rhubarb. And then I started the sour. It's more sour than bitter, I guess it is. But the rhubarb is kind of sour, but yeah, the strawberries opposing it with the sweetness, but it's just kind of automatic. I was always growing up, always have vanilla ice cream with strawberry rhubarb pie. Well, now with Spravato, we've realized we don't always have to add that antidepressant. You can use the Spravato by itself, just like you could eat the strawberry rhubarb pie by itself. So twice a week the first month, once a week the second month is how it's been studied. And then thereafter, people can use it perhaps at less frequencies. Spravato works primarily on the accelerator of the brain, which is a chemical called glutamate. Glutamate's out here in the gray matter. It's about 80% of the neurotransmission in the gray matter. And basically, it works as an accelerator on the brain. It, within a matter of hours, can make the neurons more fluffy. It's thought that people with chronic depression and chronic unmitigated stress, they just are overwhelmed with stress, they get less fluffy neurons. We've got about 100 million neurons in our brains. So we got all these neurons in our brains, and they can become less fluffy if you are under lots of stress or you're chronically depressed. It's not that the neurons die off, it's just that they become less fluffy. So with the less fluffy neurons, your brain doesn't focus as well. You have trouble with motivation, processing information, concentrating, finding joy in different things. If you can make the neurons more fluffy, it can reverse the process. And in the case of Spravato, it can do so in a matter of hours for some people, such that about 1 out of 6 people get a dramatic benefit with just one treatment. For most people, it takes 2 or 4 treatments over the course of a week or two. But for some people, they can get a dramatic improvement within just one treatment. So we've been using Spravato now since 2019 in psychiatry. And Spravato is entirely different than other medications that primarily affect norepinephrine, serotonin, and dopamine. Now, those medications that have been around for 60 years, and there's 23 of them, I think, they've been around for 60 years. They primarily affect norepinephrine, serotonin, and dopamine. If you think about norepinephrine, serotonin, and dopamine, they're kind of sitting in the driver's seat, whereas glutamate is the accelerator, and then there's a brake called GABA. So glutamate and GABA are always in balance with each other, and that's kind of like a teeter-totter. So glutamate's the accelerator, GABA's the brakes, then you got norepinephrine, serotonin, and dopamine out here giving advice to glutamate and GABA. So the medications that affect serotonin, norepinephrine, and dopamine, the traditional antidepressants we've had for the past 60 years, yeah, they have their purpose. It's just that they, in many cases, kind of poop out. They don't give a long-lasting effect, and that's why so many people go from one antidepressant to another. They have other medications added on to try to help them out. It's kind of like going to a steakhouse and getting the steak sauce added on to your steak in those cases. The antidepressants that we've had for the past 60 years just haven't done such a good job by themselves. So now we have Spravato as a nasal spray that can give people very, very quick relief. Thanks for your call. Let's go to our next email question. Our next email reads, Dear Dr. Farber, what's the percentage of people that need therapy versus the percentage of people that need medication? It all comes down to the nature of the problem. Now, think about epilepsy, okay? If you have epilepsy and you've had ongoing seizures, you want to be on an anti-epileptic medication. Your goal should not be, gee, how long do I need to stay on this? Your goal with epilepsy is to stop the seizures. The goal with depression, anxiety, ADHD, psychosis, whatever the nature of your problem should not be how long do I need to take this medication. It's how can I feel well and get my life back. So the number one goal in treatment with any psychiatric medication is to allow you to feel well. So where does therapy come in? Well, back in the 1980s, despite my previously being trained as a pharmacist, I went into psychiatry, and our main treatment for depression, anxiety, a lot of conditions back in the 1980s was psychotherapy. So I learned a lot of psychotherapy back in those days, but I found that a lot of people just didn't do well over the course of time with psychotherapy alone. Prozac or fluoxetine came out in 1987. It was the first antidepressant that was highly tolerable, and at that time, people could at least function better on a medication like Prozac. And I found that when they could function better with the medication and their brain was working, they could then have better outcomes with counseling and psychotherapy. So whereas before we always had psychotherapy and counseling first for several weeks, and only as a last resort would we add on medication, we often will start medication now as a means of helping people process information and be able to understand the whole nature of psychotherapy itself. So now we will often augment psychotherapy with medication, but for some people, medication might be all they need. With some people, psychotherapy might be all they need. For instance, if you have difficulty with finding meaning and purpose in life, and that's primarily your main symptoms, if you have trouble with communicating with your spouse and other people around you, and those are your main symptoms, maybe psychotherapy is all you need. But for many people, they have trouble with their brain working. And when your brain doesn't work, you don't sleep properly, you can't concentrate, you have difficulty with processing speed of your brain, you have trouble with enjoying things, you don't have the motivation to do the things that you're often coached to do in counseling. So with the medication, the first goal always is to make you feel well. Now, will there be a time for some people where they don't need the psychotherapy over the course of time? Maybe, but for many people, it's kind of like fertilizer. With fertilizer, with your plants, okay, you might need higher doses early on, but as time goes on, you still need the fertilizer, but you might not need it as frequently as you used it before. So we'll often use medications, perhaps at lower amounts. I don't know, Spravato being a medication that kind of acts as a fertilizer for the brain. who knows, maybe people can get to a point where they don't need it as much over the course of time, and that's what we often see. But we have to remember, people have different genetics. They have different life experiences. If you've been traumatized as a child, primarily before the age of 8 years old, you're much more likely to have depression and anxiety later on compared to somebody who wasn't traumatized later on. Coping mechanisms as an early child will be a big factor as well. So we have to remember that we can't pigeonhole everybody into the same box if they have similar symptoms and say, well, gee, he went off his medications after 2 years. Why is he still on medication? They had the same symptoms. Well, they had different genetics. They had different past experiences. They had different coping techniques. So we try to limit the medications the best we can, but our first goal for everybody will be wellness. We've got about a minute to go here. I'm going to take another call here. Greg, welcome to Matters of the Mind. Greg, you've been mentioning feeling very isolated since your spouse passed away. And what can you do to feel less isolated when you cannot get around very well? When you mention cannot get around very well, it might be because of the sadness or depression. If you're incapacitated with sadness and depression, see your primary care clinician because, number one, if you're having any trouble sleeping, that can be a big factor. Number two, if you're having trouble with your diet because of your grief, that can be a factor. When you're functionally impaired due to grief, that's when you need to see your primary care clinician to try to get out and about and do other things. You know what you need to do. You need to socialize, be around other people. Thanks for calling. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues, you may email me via the internet at mattersofthemind, all one word, at WFWA.org, and I'll see if I can get your question next week. I'm psychiatrist Jay Farver, and you've been watching Matters of the Mind on PBS Fort Wayne. God willing and PBS willing, I'll be back again next week. Have a good evening. Good night.
Preceding program on PBS Fort Wayne was made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.